Welcome this evening, everyone. I'm Addie Ferber. I'm the Executive Director for the Academy for Surgical Coaching, and I would like to welcome you to this webinar. Today, we are going to be hearing from Dr. Jason Pradarelli about surgical coaching and how it fits in with accreditation and certification requirements. So before I hand it over to Jason, I would just like to let you know of some upcoming events for the Academy for Surgical Coaching. We will be hosting training sessions for new surgical coaches in October and in January. Look to our website and join our email list for announcements when those dates and the registration opens. Second of all, the Academy is happy to announce that starting in mid-August, we will be opening up our one-on-one coaching program. So any surgeon interested in working with a surgical coach may come and connect directly with the Academy, get partnered, and start to improve how they do surgery. So about today's webinar, I have a couple of logistical elements. One, just to let you know that the chat is open for this discussion, and I'd encourage everybody to post your comments or thoughts down in the chat. Following Jason's presentation, we'll have a moderated question and answer session. So if you'd like to ask a question, please leave it down in the chat, and I'll be able to ask that at the end of the session. The slides for this session will be made available after the session over email to registered participants. So look for an email after the session with a link. Additionally, we will be posting a recording of this session to the Academy for Surgical Coaching channel on YouTube. Look for, again, a link for that. We'll be sharing it over email and pushing it through Twitter as well. So with that, I'd like to do a brief introduction. Dr. Jason Pradarelli is the Medical Director for the Academy for Surgical Coaching. I'm overjoyed to have him as a member of our team, and he has recently published an article in the American Journal of Surgery on this idea of the relationship between surgical coaching and continuing board certification. So with no further ado, I will hand over to Jason and let you take it away. I'll be back at the end for Q&A. Thanks.
Great, thank you, Addie. Welcome, everybody. This is one of several information sessions that the Academy for Surgical Coaching is going to be hosting for free as part of our educational efforts in the upcoming year. As Addie mentioned, my name is Jason Pradarelli. I'm the Medical Director at the Academy for Surgical Coaching. I'm also a general surgery resident at the Brigham and Women's Hospital in Boston. Today's discussion is centered around the vision for the future of continuing board certification, a report issued last year by the American Board of Medical Specialties. Recertification has evolved slowly since it was introduced over 40 years ago, so this is an exciting opportunity to upend that process for surgeons in practice. This is a window of opportunity for disruptive innovation in surgical quality, education, and culture. Today we'll discuss the historical context for board certification in surgery, interpret how the ABMS vision for the future applies to surgeons, and highlight recent developments in video-based assessments and peer surgical coaching. Since the earliest days of the profession, physicians have had both the privilege and the responsibility of self-regulation. Traditionally, board certification has been a key mechanism for each specialty to ensure trust from both fellow physicians and the public in our self-regulatory abilities. That is, board certification needs to mean something substantial. However, while the end goal of certification is to ensure high-quality patient care throughout one's career, many physicians have questioned the value of maintaining board certification in its current state. In our recent review article in the American Journal of Surgery, we outline these concerns generated by others. Primarily, this is time and financial burden of test prep, redundancy of requirements for recertification, irrelevance to surgeons' everyday practice, and inadequate adaptation to today's subspecialized practice patterns. To address these major concerns, the ABMS commissioned a group of stakeholders across healthcare to develop a roadmap for redesigning the continuing certification process and why that should differ from initial board certification at the end of training. In response to their final report, the American Board of Surgery, or the ABS, convened a retreat with directors and experts in surgical education and quality to discuss approaches for fulfilling this vision in surgery. To understand why now is such a key moment for disruptive innovation in surgery's board certification process, we need to put today's environment in context of prior efforts to tweak the process for surgeons. In 1937, the ABS was founded. they initially issued a board certification as a one-time lifetime credential that was valid for a surgeon's entire career. The first certifying exam was actually 2 days long, in person, and actually involved direct observation of a surgeon providing patient care in the clinic and in the OR. This was abandoned shortly afterward due to issues scaling up these formal assessments and an eventual change in location from medical centers to hotels for these tests. 1976 was marked by a change from a lifetime credential to a time-limited credential, requiring that surgeons recertify every 10 years, mainly through a high-stakes, point-in-time written exam that was designed to assess knowledge and clinical judgment. This was important because it was the ABS's first acknowledgement that surgeons needed to stay current throughout their career regarding advances in medical science and patient care. With the rapidly evolving nature of medical science, in 2000, continuing professional development was encouraged, where we still had the recertification exam every 10 years, but now we added the requirement to account for 100 hours of continuing medical education credits, or CME, in the 2 years leading up to the exam. CME is the current standard way of getting credit for professional development. In 2005, the ABMS developed the Maintenance of Certification, or MOC program, which has generated plenty of backlash. The ABS then had to develop surgery-specific MOC requirements, including the same high-stakes written exam every 10 years, but now with the added explicit expectations of professionalism, lifelong learning, and improvement in medical practice. It's proved difficult to implement this holistic approach to evaluating surgical performance while still adhering to the traditional structure of available professional development activities. Notably, these are conferences, weekend courses, cadaver labs, or short certificate programs like FLS, Fundamentals of Laparoscopic Surgery. In 2018, responding to the concerns of MOC, the ABS's response was continuous certification. This was a lower stakes exam that was now required every 2 years with fewer questions. It was open book, and some specialties had customizable modules in an attempt to address practice variation. CME requirements were actually lowered in 2018. In retrospect, these changes were incremental tweaks that were reactive to backlash in the medical community, but really were not substantial changes in how surgeons were expected to assess and improve their performance throughout their careers. It's important to note that the 4 components of MOC were the expectations for practicing surgeons. They're what's supposed to happen for a physician's professional development, but they've proven to be difficult to implement in real life. The biggest visible change over the years has been Part 3. That's the written assessment of knowledge and judgment. But even as this exams change over time, skills haven't truly been assessed for proceduralists like surgeons. Part 2 is lifelong learning and self-assessment. These requirements are checked off by an existing smattering of CME activities whose true value many others have already questioned. What assessment really looks like in real life for surgeons is a deterioration after formal training. While residency and fellowship are defined by educational environments that support continual development of surgical knowledge and skills, this environment largely evaporates when surgeons enter professional practice. Similar to in-service exams and board exams in training, current recertifying exams are summative, sit-down assessments that struggle to reflect real-life practice patterns. Feedback on one's performance, while a challenge even at the residency level, drops off steeply in independent practice. And how can you expect to improve on something that's not even assessed? Furthermore, how can you improve if you don't know which data is yours? The interesting loophole of MOC is that Part 4, or improvement in medical practice, counts if a surgeon's institution contributes data to an outcomes registry, regardless of whether that data is fed back to the surgeon or acted upon. This 4th component of MOC is supposed to be a surgeon-level requirement, but what really happens is institutional participation in an outcomes registry, and there's hard evidence to show that simply contributing data to an outcomes registry does not improve practice on its own. These 3 studies listed here from 2014 and 2015 reported null findings on surgical outcomes for institutions that contribute data to national registries. That's to say, individualized data that's buried in an institution's database is not useful for helping surgeons improve if it's not accessed and utilized. We owe it to ourselves and to our patients to do better than simply checking a box for recertification requirements. And ABMS made this clear in their Vision for the Future report. So recognizing challenges of implementing professional development programs that achieve overarching goals of continuing certification, the ABMS organized the Vision Commission as a group of 27 individuals from diverse backgrounds in healthcare who are charged with reviewing existing professional development activities to ensure that continuing certification truly supports lifelong improvement for physicians and patient care. The Commission issued 14 recommendations for change in their 2019 final report. I'll highlight the most important recommendations of the Vision Report for surgeons. In this report, they said that continuing certification must change to incorporate longitudinal formative assessment strategies. That's rather than the burdensome, highly secure, summative exams that currently exist. They said that continuing certification should differentiate itself from initial board certification by ensuring that assessments are grounded in adult learning principles, especially for fully trained professionals like practicing surgeons. This means that learning should be frequent and spaced apart with timely feedback to support continual learning, repeated assessments to reinforce these lessons, and importantly, analysis of gaps to focus physicians' improvement efforts. Especially relevant for surgeons, procedural skills must be incorporated into continuing certification programs as the technology advances to support practical skill assessments. So with this charge, the ABS and the field of surgery have an exceptional opportunity to lead all of medicine in strengthening professional development, rather than being left behind with the burdensome existing processes. So a key takeaway from this vision report was that to improve surgical performance, we must first reliably assess performance. Surgical performance can be broken down into several distinct but interdependent skill domains that enable surgeons to accomplish the task of an operation. Distinguishing these skill domains provides a scaffold that we can define, measure, and improve surgical performance in manageable components. Technical skills are the most easily recognized skills for surgeons and are the physical motor skills necessary for completing an operation successfully. Examples of technical skills include respect for tissue exposure, and operative flow from step to step. Non-technical skills are the cognitive and interpersonal skills that underpin knowledge and expertise in high-demand workplaces such as the operating room. Cognitive skills are the more internal skills to a surgeon's mind, such as situation awareness, decision-making, and intraoperative judgment. Interpersonal skills are more the externally visible skills for surgeons, such as team communication and leadership. Self-regulation has also been shown to be an important factor for surgeons to complete an operation safely. Stress management and coping strategies are some of the factors in self-regulation in the OR. As we discussed in the history, assessing performance is a cornerstone of board certification. Recall that the first certifying exams actually involved direct observation of patient care. Skill assessment is critical because better skills correlate with better outcomes for patients. This sounds intuitive, but here's evidence to back it up. Many of you may be familiar with the Berkmeyer study of certain technical skills from 2013, where bariatric surgeons were rated using an anonymous video of them performing gastric bypass. Surgeons were asked to submit a video of their typical case. Of course, they submitted their best cases, and blinded peer raters scored their technical skills. Among practicing surgeons, there was significant variation in skill ratings. But even more important was that those ratings correlated inversely with post-op complication rates. So surgeons that had the highest skill ratings had 3 times lower complication rates compared to surgeons with the lowest skill ratings. This relationship also holds true for non-technical skill performance, as demonstrated in a separate body of literature. To measure surgical skill in modern times, technological advances now offer surgeons better access to their own performance assessments. In the context of the ABMS Vision Report, we believe that the ABS has a duty to help surgeons utilize this data for performance improvement. Advances in video capture, data storage, and video processing now support the scalability of video-based assessments in surgery. We can hone in on technical skills using operative field video from laparoscopic or robotic systems. Some professional societies, such as SAGES and ASCARs, are already developing specialty-specific measures of technical skill using video-based assessments. Some platforms even have the capability to capture full OR audio and video to focus on room dynamics and non-technical skill assessment. So video-based assessment offers the ABS an opportunity to return to its roots in a way that addresses many of the barriers of direct observation that they encountered in the original certifying exams. We believe that video-based assessment should be a foundation for efforts to strengthen the continuing certification process in surgery. After collecting data on outcomes, intraoperative performance through audio-video, and doing a video-based assessment, a critical next step for fulfilling the ABMS vision in surgery is to is how surgeons can act on these assessments to improve their performance in everyday practice. This is where surgical coaching can effectively enter the ABMS's strategic plan. Coaching is on the rise in America. You look around and you'll see coaching services available for almost everything. Leadership coaching, life coaching, parent coaching, family coaching. I've even seen coaching for training your pets. You can type coaching into Google and the search term actually combines results for teaching, mentoring, and training, but these are distinctly different, and it's important not to conflate coaching with the other terms. So I'm going to transition now into what is coaching and what does coaching mean for surgery. So coaching focuses on growth of the individual rather than simply transmitting knowledge from one to another. Coaching first and foremost respects the autonomy of the individual and their identity as a fully trained professional. Coaching is all about guiding an individual by listening and observing, asking insightful questions, and importantly, inviting a response to the feedback that's given. It's equally important to note what coaching is not. Coaching is not telling people what to do. It's not criticizing, and it's not instructing in the moment about what somebody should do. So in surgery, peer surgical coaching is a partnership between a surgeon and a coach, who's also a surgeon, where the coach empowers the surgeon to improve their performance through a longitudinal series of one-on-one reflections about their own practice. Adult learning principles apply here through constructive feedback to help surgeons identify their performance gaps, set individualized goals based on those gaps, and to determine an action plan to achieve those performance goals. For continuing certification, coaching builds on video-based assessments by providing a mechanism for surgeons to act on their own performance data. So can coaching work? Outside of surgery, coaching seems natural. We see coaching used most obviously in athletics, although the degree to which sports coaches adhere to the coaching principles varies widely. The Bobby Knights or the Jim Harbaughs or others who fall into this yeller category are not what we're talking about today. Individual sport athletes, group and solo musicians, classroom instructors all routinely use coaches to improve their performance throughout long and successful careers. As you might ask, can coaching work in surgery? Evidence is being published as we speak. Video-based surgical coaching has been shown to improve operative performance among medical students and residents, and for practicing surgeons, it's been shown to improve technical skills in simulation settings. Trials of coaching among practicing surgeons have yet to demonstrate similar improvements in clinical skills or clinical outcomes, but several reports have shown that surgical coaching programs are feasible among surgeons in practice, have high perceived value among the participants, which is important because it contrasts current CME activities, and it can also result in downstream practice changes such as adoption of challenging techniques. The literature is also growing to provide scientific evidence for implementation strategies for peer surgical coaching programs. So yes, coaching can work in surgery. From the momentum generated from these research programs, the Academy for Surgical Coaching was born. This was founded last year as a nonprofit organization. The Academy strives to improve surgical performance through a national platform for surgeons to engage with a coach. Our founders and team members bring a diverse set of expertise to the organization, importantly including surgeons themselves, researchers, education and video technology experts, and professional coaches. In practice, you might wonder, how do we possibly get a busy surgeon and a busy surgical coach to sit down with each other and do coaching? Trust me, it's not magic, and we make it as practical as possible, knowing personally how challenging it can be to fit professional development into a busy surgeon's life. First, we train surgeons to become surgical coaches, as there's best practices and data to support the intentional adoption of core principles and key skills of coaching. We next pair surgeons who are looking to receive coaching with a trained surgical coach. This is a customized process that's tailored to the individual surgeon's needs. It's critical that the surgical coaches and surgeon establish rapport before initiating their coaching sessions. So we facilitate a get-to-know-you session on a video call or face-to-face, of course, when it's safe to do so. In a video-based coaching model, we provide this platform for surgeons to exchange operative video for review with their coach. This model gives the coach a chance to review their operative video beforehand, and during the sessions, the surgeons can debrief at their convenience in a confidential setting away from the OR and concurrent clinical activity. The coach is trained to guide a surgeon through goal setting, inquiry, constructive feedback, and development of an individualized action plan to help the surgeon implement practice changes discussed. Each session can take up to an hour, and we encourage 3 to 4 sessions over the course of several months, depending on the individual surgeon's performance goals and their availability. Importantly, part of the action plan is for the coach and the surgeon to reassess the surgeon's progress over time. In this way, surgical coaching enables surgeons to achieve the fundamental goals of the ABMS vision for continuing certification. So this endeavor has sparked unique collaborations with industry to support the technological advances leveraged with video-based coaching. And it's exciting to see both new and well-established companies evolving an entire industry to support this professional development work in surgery. With this support, surgical coaching promotes all the tenets of continuing certification, especially professionalism in the practice, lifelong learning with both self and peer assessment, and uniquely, ongoing skill development for improving surgeons' patient care practices. Most importantly, to implement surgical coaching as a sustainable strategy, regulatory bodies like the ABS need the buy-in and collaboration of the major surgical societies. Given that the ABS membership is represented by many major societies, including subspecialty groups, the mission and activities of the ABS and societies are highly complementary. Collaboration among these organizations would be mutually beneficial to the organizations themselves and the surgeons they represent. Ultimately, improvements in surgical performance benefit our patients. Establishing surgical coaching is an expectation for surgeons' lifelong professional development would both promote the best patient care possible and engender the public's trust in our profession. I appreciate you all tuning in today, and at this point we'll open it up and check the chat for questions, feedback, criticisms, pushback, whatever you got. Thank you for being here tonight.